Next chapter is going to be chapter 3, the ovaries. Now, first let's discuss the simple cysts. Simple cysts are generally a physiological cyst, which can be a luteal or follicular cysts. These are most common during the reproductive years. They are generally asymptomatic until they either become very large or they burst. Torsion can occur when they're very large, and that's why they would become symptomatic. Ovarian cysts, you can see your normal ovary here at the top and then your cystic ovary here at the bottom. This is an ovarian cyst seen on laparoscopic. Now, with your simple cyst, the beta-HCG is usually negative unless they're pregnant. You can have simple cysts even when you are pregnant, but generally for the exam, you will have a negative beta-HCG in the question, just so that you know. An ultrasound will show a fluid-filled simple cystic mass. Management. How are you going to manage these simple cysts? You're just going to basically follow them up in 6 to 8 weeks. They generally resolve spontaneously and you don't really need to do anything. Once they resolve, you can give steroid contraception, which will then prevent any new cysts. When are you going to remove the cyst or do a cystectomy laparoscopically? You're going to do that when the cyst is bigger than 7 centimeters or if your previous steroid contraception had failed to resolve the cyst. Complex cysts. Complex cysts, the benign ones, are also called dermoid cysts or benign cystic teratoma. They contain the 3 germ cell layers. Rarely, squamous cell carcinoma will develop. In ultrasound, you're going to see a complex mass. Management. You're going to have a laparoscopic removal or a cystectomy, which basically removes just the cysts and leaves the ovary the same, or an oophorectomy, which means removal of the ovary if your fertility is no longer desired, such as in postmenopausal women or in women who just don't want to have babies. A 31-year-old woman presents to the ED with severe, sudden, lower abdominal pain started 3 hours ago. Her abdomen is tender, but no rebound tenderness is present. There's an adnexal mass, and ultrasound shows an 8-centimeter adnexal mass. Here's your key: is your beta-HCG is negative. The reason they tell you your beta-HCG is negative here is because they don't want you to think it's an ectopic pregnancy. If the test wants you to answer something about a simple cyst, they have to make sure that you know it's a simple cyst. If they want you to answer something correctly, they have to tell you something. So what's going to be next? An appendectomy, give high-dose estrogen and progesterone, laparoscopic evaluation of the ovaries, observation, or perform an oophorectomy. Now, didn't we talk about this? We wanted to do a laparoscopic evaluation of the ovaries and may need a cystectomy. But we want to make sure that the ovaries are okay because it's more than 7 centimeters. She is 31 years old, so most likely her fertility is important to her, so you wouldn't just perform a oophorectomy. Now, anytime there's ovarian enlargement, it's always suspicious for a neoplasm, especially in the prepubertal patients and the postmenopausal patients. Your risk factors are going to be a BRCA1 gene, a positive family history, a high number of lifetime, ovulations, and infertility. Your protective factors are going to be conditions that decrease the number of ovulations. So, what decreases your number of ovulations? When you take oral contraceptive pills. That does not allow you to ovulate. So that's actually protective. Chronic anovulation, breastfeeding, and a short reproductive life because you have less number of ovulations. What's your diagnosis? Which cancer in the following cases and what tumor marker makes it? There are a bunch of different types of tumors, but generally only one type of case goes with each type of tumor. So, like I said before, if the test wants you to answer the specific answer of this specific tumor, they're going to have to tell you something. So, 9-year-old girl, right adnexal pain, complex cysts on ultrasound is most likely going to be a germ cell tumor. Why? Because it happens commonly in young women. It presents in the early stages, and it's the most common malignant epithelial cell is dysgermoma. What are your tumor markers? They're going to be LDH, beta-HCG, and alpha-fetoprotein. In a 67-year-old woman with progressive weight loss, a distended abdomen, and a left adnexal mass. What's that going to be? An epithelial tumor. So most common ovarian cancer in postmenopausal women. That's why the patient was older. The most common malignant subtype is going to be a serous tumor. What are your tumor markers? They're going to be CA125 and a CEA. 58-year-old postmenopausal, endometrial biopsy shows endometrial hyperplasia, and your pelvic ultrasound shows a right ovarian mass. So basically, if you're having endometrial biopsy with endometrial hyperplasia, that probably means that they have a high estrogen level. So that is associated with a granulosa thecal cell tumor that secretes estrogen and can cause endometrial hyperplasia. Your tumor marker is going to be estrogen. In a 48-year-old woman with facial hair and a deepening voice and an adnexal mass found in an exam. Well, facial hair and a deepening voice is associated with testosterone, right? So that's going to be a Sertoli-Leydig tumor or a stromal cell tumor. That one secretes testosterone, so it presents with masculinization syndromes. Your tumor marker is going to be testosterone. A 64-year-old woman with gastric ulcer and dyspepsia with weight loss and abdominal pain, an adnexal mass is found. All right, so which one of the tumors is associated with gastric ulcers and dyspepsia? Well, it's going to be a Krukenberg tumor. Krukenberg tumor is a metastatic gastric cancer that has metastasized to the ovary. It's a mucin-producing adenocarcinoma, and it is metastasis from the gastric CA. Your tumor marker is going to be a CEA. Management for all of them is going to be a sonogram. For postmenopausal women, or once it's been confirmed, it's going to be a CT scan. You're going to do biopsies via laparoscopically. It can be done for simple cysts or simple cysts. Simple cysts means no septations or solid components. And it's also done in postmenopausal women without ascites. Your tumor markers are going to be extremely important, as they will also help you define which, in real life, help you define which tumor it is. And a cystectomy will be done for if there's benign tissue around it. For premenstrual women, you're going to do a salpingo-oophorectomy. What does that mean? You're going to remove one ovary and one fallopian tube because you want to remove the cancer, but you want to preserve their fertility. In postmenopausal women, you're just going to do a total abdominal hysterectomy and remove everything. You'll also do a bilateral salpingo-oophorectomy, and you may need to do post-op chemo for malignant tissue. That's the end of chapter 3. I'll see you in chapter 4.